Hello, this will possibly be the last lecture I actually have to do for special topics for PTA208 for the cohort 10. So this is just going to be a supplementary lecture to the one that you will have live tomorrow. And it is on obstetric health and incontinent patients. So let's begin the lecture here. Right, so this is your ligamentous anatomy. You should have covered this way back in semester 1 and semester 2 with anatomy and physiology. As you can see, the main thing I wanted to show in this overall picture is how the ligaments form that pelvic sling that's in there, right? You can see it forms a very much like a hammock structure inside of your pelvis, and that's going to support all your muscles, primarily of both sexual reproduction as well as urination and defecation as well. So here's kind of a view of it from a model standpoint. And you can see again, there's not a lot of room for all this stuff to be in there. So I'm going to understand the physiological impact of pregnancy on the body, describe maternal and fetal responses, identify precautions, contraindications, talk about pathologies and interventions is kind of the main goal for today. All right, so obstetric patients or pregnant patients, anatomical and physical changes of the bodies. Women typically, when they have children, are going to gain between 25 and 35 pounds, some a little bit more, some a little bit less. The ligaments connected to the pelvic organs contain increased fibroelastic properties than normal musculoskeletal ligaments, which means those ligaments are just a little bit stronger than something like your ACL or your PCL, so they allow them to stretch a little bit longer. The kidneys themselves are actually going to increase in length about 1 centimeter. Doesn't seem like much, but the kidneys, that's huge. The ureter's angle in relation to the bladder changes and becomes more perpendicular versus vertical, and that can lead to increased risk of UTIs, right? Because the urine can get kind of stuck in it and not progress down to the bladder. So it'll end up with what's called urinary stasis. Obviously, there are going to be some hormonal changes that can lead to edema, tissue congestion, upper respiratory tracts, which can lead to respiratory secretions and can lead to all kinds of major problems with breathing itself. But on top of it, you got baby who is pressing down on all of the internal organs as well, which can lead to respiratory functions. The ribs flare up and out, resulting in increased chest circumference. It also may not return to normal after pregnancy, which leads you to have that inability or the inelastic chest function. The diaphragm gets elevated. Well, obviously the diaphragm is going to elevate because you don't have baby. You have that nice little parasite growing in you. Progresses through pregnancy into the last few weeks. Once the baby drops down the pelvis before delivery, the depth of respiration increases. Tidal volume increases, but total lung capacity is unchanged. That means that stuff that's just resting in your lungs stays there a little bit more. Worker breathing's increased due to hyperventilation. Again, mom is now breathing for 2. That's why there's a 15 to 20% increase in oxygen consumption. And shortness of breath is often noted with even mild exercise. Blood volume increases by 35 to 50% and will eventually return to normal. It consists mainly of plasma, which can lead to physiological anemia. So they actually start having problems with red blood cells and stuff like that. Venous pressure in the lower extremity increases, obviously, because baby again. So the inferior vena cava pressure raises, especially in supine, which is why we don't want them in supine very often. Can lead to an aortic conclusion in supine or right side lying. So left side lying creates the least amount of pressure. So if your patient's going to lie down, ideally they should be in left side lying. Blood pressure varies greatly throughout the entire pregnancy, dropping for the first few weeks, and then at midterm, and then it starts going back to pre-pregnancy levels afterwards. The heart itself is enlarged and elevated due to the diaphragm. Some women experience changes in rhythm as well. The heart rate increases by 10 to 20 beats per minute. Once again, she is now beating for 2 people. Cardiac output increases are 30 to 60%. Again, 2 people. Abdominal muscles are stretched to their limit by 40 weeks. In the stretched position, they have very poor contractibility. And the mechanical advantage of these muscles is lost due to the shift in the center of gravity because mommy is now kind of leaning forward. The ligaments have a degree of tensile strength due to hormonal changes. Relaxin gets secreted by the ovaries, the breast, and placenta. And progesterone secreted by the ovary, placenta, and adrenal glands. This results in joint hypermobility, making the patient more prone to ligamentous injuries, especially with the weight-bearing joints. So they often get pain in the low back, pain in the pelvis, pain in the lower extremities. And that's why we want to be careful if we're doing any form of mobilizations with them or any type of joint mobs, anything like that. Pelvic floor will eventually drop due to the weight of the uterus, and it can be stretched, torn, or incised during delivery. Episiotomy is where that actually tear occurs, right? So at the episiotomy, there's only a skin tear, right? The second degree includes skin and underlying muscle in the vaginal canal. Third degree extends to the anal sphincter, and then fourth degree tears into the rectum. So you can see how that would all be kind of dangerous for the woman, right? And opens it up to potentially all kinds of infection. The pudendal nerve, which is the main nerve of the perineum, can be stretched or compressed during delivery of the baby's head and during vaginal delivery. So both pudendal and sciatic nerve are both subject to getting all kinds of problems going on, just being compressed, having pain, stuff like that. Basal metabolic rate and heat production increases, makes mom often frequently very warm. Shoulder girdle and upper back become rounded into scapular protraction. The upper extremities become internally rotated. So they've got that typical, what we call texting posture. That means that everything up front is super tight. That means we should not be stretching them into protraction. We should stretch them back into retraction. Cervical lordosis increases. Lumbar lordosis increases. Weight shifts posterior to adjust the center of gravity. And then after birth, the child care activities don't exactly promote a healthy correction of the changes, right? Because oftentimes after birth, when you're taking care of the baby, a lot of time you're spending bent over the baby's cradle or the bent over the baby's changing table. And that then obviously leads to further continuation of the pain and the problems they had during pregnancy. Increased rate and weight and redistribution of the body mass needs to compensate, right? They usually go to a wider base of support, and they usually start externally rotating and turning the feet outwards. Diastasis recti is probably one of the words you'll hear that most women are worried about. This is where the rectus abdominis muscle separates, and that's usually right at that linea alba. And it can be greater than 22 centimeters, where we get abnormal. Should always be tested on the patient postpartum before beginning any abdominal exercises, right? There should be information on that before we start any abdominal exercises, because vertical abdominal exercises are going to be problematic. The straight up standard crunch or sit up are going to be a problem if they have this diastasis recti. Low back pain and pelvic pain, probably one of the most common complaints you're going to get. It's due to the postural changes, increased ligamentous laxity, and decreased abdominal strength and function. So they're starting to rely on that low back for all their work. Getting that pelvic girdle and the back muscles getting pulled on. Education exercise is the best treatment. Don't do deep heat, stim, or traction on the low back because, again, baby, that includes ultrasound. Symptoms simply resolve postpartum if they can. If good body mechanics are utilized, they will go away. SI joint pain is likely due to ligamentous laxity and postural alignment as well. External stabilization may help. So if they start having an SI joint, some will result tighten. They'll say, when I put my belt on or when I tighten my pants, it feels better. What that's doing is kind of compressing that low back and closing off that SI joint, so that makes it very comfortable. Even in adults, a lot of times they'll say, I've got low back pain until I put my belt on. As soon as I put my belt on, I feel so good. Well, it's because the belt is kind of locking in that SI joint, and that's why it's relieving pain. Usually women will suffer from pubis symphysis pain or subluxation. Can happen during childbirth as well, so we have to be paying attention to that. That's where the pubis symphysis itself is either causing pain because of the stretch, or one side becomes dropped on the other. Pathology, varicose veins, often aggravated during pregnancy, so if you already have it, patients often will get more of it during pregnancy. You can wear elastic stockings or compression stockings to help relieve this. Pelvic floor dysfunction. Normal functions provide support to the pelvic organs. Well, if it's all stretched out, it's not going to have normal function. Primary nerve, obviously, that innervation of the area is going to be pudendal nerve, so S2 through S4. Joint laxity. It's caused by the hormonal changes from relaxin, possibly by the woman nursing the baby. Interventions. Low weight-bearing, non-weight-bearing activities such as swimming are ideal. Pregnant women really tend to like working out in the pool because it's a little bit lower impact, doesn't cause problems. Bike riding is also, again, recumbent bike probably best. Walking, low impact aerobics is also recommended. Compression syndromes, right? Thoracic outlet syndrome, carpal tunnel syndrome, ulnar tunnel syndrome, and even tarsal tunnel syndrome can occur from the increase in postural changes, fluid retention, and all the stuff that goes along with being pregnant. For those disease or those disorders, you're going to have to treat them symptomatically. Postural correction exercises, ergonomic assessments, heat and ice as needed as long as it is away from baby, splinting as needed if they need bracing. Pelvic floor can also end up with prolapse if any of the pelvic viscera are out of normal alignment. Urinary fecal incontinence is pretty common for pregnant women, unfortunately. So for those of you that are interested in getting pregnant, this just is kind of telling you what can possibly happen to you. Pain and hypertonus is also really common in the pelvic floor. So what do we do with Therex? Well, we're going to increase pelvic floor strength by doing pelvic floor exercises. We're going to re-educate those muscles. Superficial heat and ice is okay only if cleared by the PT and typically in distance away from the baby. TENS and E-stim can be helpful postpartum, but not during it. We don't want to shock baby. Biofeedback is usually very useful. We're going to avoid single leg stance activities for pregnant women. That kind of makes sense. Keep supine to a maximum of 5 minutes until after the 4th month. So once we're at 4th month, we shouldn't be doing a lot of supine activities at all. Right side lying is included in that as well. Have the patient empty the bladder prior to exercise. So guarantee you're going to bring a pregnant woman back to treat, and all of a sudden she's going to say, I've got to go to the bathroom. And so then you've got to go ahead and wait on that and blah, 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 blah. So you might as well make sure as you're bringing her back to therapy, say, have you used the restroom recently? Okay, if you haven't, let's go ahead and use it now so that we can be sure that, we can get through this as soon as possible. Monitor for any types of signs for bleeding or pain, right? So anytime the patient has any potential sign of bleeding or pain, we need to discontinue therapy. So you have to be paying attention. Absolute contraindication. So at this point, they should have no therapeutic exercise. Incompetent cervix, right, where they end up with early dilation, should be avoided. Vaginal bleeding of any amount, even if it's just a small amount, it's only a little bit, doesn't matter. Stop Therex. Placenta previa, where the placenta lies low in the uterus and partially covers the cervix, that would be a definite hard no Therex. Any rupture of membrane where you have loss of amniotic fluid. Maternal heart disease, maternal diabetes, or hypertension. So any problem with the heart or your endocrine system, you want to watch out for. And anything where you have that intrauterine growth retardation, where the baby doesn't have room to grow, you want to avoid it. Precautions, multiple births. If the patient is likely to have twins, triplets, quintuplets, octuplets, anything like that, that's a precaution. We got to be careful when doing exercise with them. If they're anemic, they should be seeing their doctor to make sure they take anything they need to make them less anemic. Systemic infections. They get a systematic infection. We want to make sure we are really, really cautious about what we do with them. Any extreme fatigue, musculoskeletal complaints or pain, we got to pay attention to. Severe overheating, right? Phlebitis, or inflammation of the blood vessels. We get the diastasis recti down there. And then especially if we're exercising and they start getting contractions every time we exercise them, we've got to be paying attention to these things. Urinary incontinence. So now we're switching from the pregnant woman to an incontinent patient, right? So it doesn't mean that pregnant women can't be incontinent, but now we're talking more about your average ordinary incontinent person, right? Incontinence in a patient may have trouble starting urine stream or holding urine stream, or any type of problem that occurs with either urine or fecal incontinence. So if there's a problem with it, that can be considered incontinence. Urinary incontinence involves the muscles of the pelvic floor, but it also involves the nerves affecting the pelvic floor. The muscles attached to the bottom of the pelvic bone run from front to back, forming that bowl-like structure, and it supports the internal organs and controls the sphincter muscles. Pelvic floor muscles also support the low back and stabilize pelvis, so a lot of times with pelvic floor, they can always have some pain with low back as well. Women are more likely to develop men and have urinary incontinence, but men can get urinary incontinence as well, and it's an actually underreported problem in the male community. Fecal incontinence is the leakage or release of fecal matter or stool at inappropriate times, and this can involve muscles of the pelvic floor or maybe an incompetent external anal sphincter as well. So different types of incontinence. We have stress incontinence. This is where small amounts of urine leak when there's increased pressure on the bladder, right? Urge incontinence, the bladder muscle goes into spasm, and if the spasm is severe enough, medium to large amounts of urine may leak. It might happen only occasionally or may happen as often as every 15 to 20 minutes. Mixed incontinence kind of is the combination between stress and urge, so you're not sure which is chicken, which is the egg. And then functional incontinence is where urine leaks when you can't get to the bathroom in time. Maybe in a patient's case where they have something like Parkinson's disease or something to that, where they just can't make it to the bathroom because they're too slow. Stress incontinence usually is a result of weakness and lack of support of the pelvic floor muscles. It can happen when laughing, sneezing, coughing, or with exercise. It can happen just as something simple as standing up. Women with stress incontinence often have underactive pelvic floor muscles, and it can be a result of pregnancy or childbirth. So the baby, again, that parasite has destroyed their pelvic floor muscles. Other injury or trauma, especially in the case of sexual assault. Surgery in the vagina or rectum can also lead to this. Episiotomies, that incision when the tear of the vaginal opening back to the anal sphincter during childbirth, and lack of general exercise and lack of use. The more we just sit, the more likely we are to actually get incontinence, right? So general exercise in itself really does help with incontinence. After delivery, women can also have fecal incontinence, leakage of stool if there is tearing, right? If we had that episiotomy going on, there's often times they're going to get fecal incontinence as well. This is not something the patient wants to talk about. I'm going to tell you right off the bat, and this can make them very uncomfortable. So moving on. Oops, went too far. Urge incontinence. With urge incontinence, the patient may or may not have pelvic floor muscle weakness. So urge doesn't necessarily mean that it actually has pelvic floor incidence. They're showing that it might be a central sensitization issue where there's an overfiring central nerve that's causing, the bladder to get spastic and empty. Functional incontinence cause isn't directly related to the bladder or pelvic floor muscles. Joint pain or muscle weakness cause the patient to move with difficulty. Confusion, dementia, delirium can be these reasons they have functional incontinence. Environmental barriers, such as the bathroom being too far away. They don't want to use their walker because it slows them down, or they feel that they can't get to their walker in time, so they can't get there, the hiccups. Too many obstacles, throw rugs, all that fun stuff, dogs, cats, bears, oh my. Psychological problems such as depression or anger, where you're just so depressed you can't even get out of bed, can cause this functional incontinence. The patient can also have an overactive bladder where the bladder empties frequently throughout the day, more than 3 to 4 hours during the day, and makes the patient get up more than once to urinate at night. So if they already have a problem with the bladder and then they can't get to the bathroom, that's going to lead to this functional incontinence. So how can we help? Well, based on evaluation results, individual treatment plans can be developed to help strengthen the patient's pelvic muscle and pelvic girdle, and help overall train the patient to gain more control over the symptoms and reduce the need for assistance pads or special undergarments, incontinence meds, and or sometimes up to possible surgery. So the key here is to find the right muscles and get using them correctly, right? We are not going to be working with our belly. We're going to be working the pelvic floor. Physical therapists can help strengthen those muscles that have control over the bladder, and that can improve. Key points to show the patient is we have to show them how to find the right muscles. Sometimes this does involve palpation. And this is one of those areas where you have to be very, very clear about what you're doing. Pelvic floor exercises help strengthen that so you can better control your bladder. The pelvic floor exercises include Kegels, which are your gold standards, in which you gently squeeze sphincter muscles and squeeze the buttocks, thighs, and stomach muscles. Instruct the patient in exercises to stretch and strengthen the other important muscles. So you stretch the ones that are tight, strengthen the ones that are weak, so they can support overall proper bladder function. Depending upon the symptoms and level of discomfort, we may use biofeedback to help them more aware of activating those muscles. Electrodes can be attached vaginally and or rectally to provide measurement of muscle activity and display them on a monitor or cause kind of that beeping noise that normal biofeedback provides. You can also do internal or manual cueing. Again, this is with palpation, properly cue which muscles to contract and which not to. This is a whole field, so if you're interested in getting this, it's very needed. So here we have an external palpation for floor contractions, teaching the patient which muscles to contract while they're doing the pelvic floor contraction or those Kegels. Again, internal palpation. This is on obviously a medical model. And then we can palpate to make sure that those muscles are fully closing. So general information for Kegels, the holy grail pelvic exercise. Have the patient should perform 45 contractions daily. 10-second sustained contraction with 10 seconds relaxation between. So you break those 45 contractions down as following. 15 standing, 15 seated, 15 supine. So if each one takes 20 seconds, right? So you have a hold, 10-second hold, 10-second rest, and you're supposed to do 15 of them. It should take you how long to complete this? 300 seconds, or what is that in minutes? About 5 minutes for each of these. So total exercise for the day for this is only going to be 15 minutes. Patients can do this, right? If the patient can't maintain the contraction for 10 full seconds, then you start with what they can. If they can only do 2 to 3 seconds, start with 2 to 3 seconds, and then just build on it every week. The patient has to be careful to only contract the pelvic floor muscles. Don't strain down or tighten the buttocks. Don't do that Valsalva maneuver. And they should be breathing, keeping mouth open, because that'll help them keep from doing Valsalva. So here's some easy instructions. Pretend that you're trying to avoid passing gas or hold in a bowel movement by tightening the pelvic floor muscles. Concentrate just on the pelvis floor and pull it up and back towards the small of your back. In women, you should have a mild aspect of the vaginal opening should move closer to your abdomen, and a closing feeling should occur, right? In men, proper contractions should cause the base of the penis to move closer to your abdomen, and your testicles should rise. That's a proper Kegel, okay? So standing, stand with your feet apart, approximately half shoulder width or to shoulder width, and tighten the pelvic floor as if attempting to prevent passing gas. Again, perform 3 sets of these exercises daily, holding for 10 seconds. Seated, sit with the chair and the knees apart and tighten the pelvic floor as if lifting the pelvis, but not the buttocks off the chair. Right? If your butt's picking up, you're not doing it right. Again, perform 3 sets of 5 exercises each day. And supine, you can lay as comfortable as possible, preferably in hook line with knees apart, and tighten that pelvic floor. So there we go. We got all 3 positions, and that will help. Even if you now know that you have problems with your pelvic health and you know that you might have one of these incontinences, just doing these exercises every day has been shown to improve that overall function. Of course, unless it's central sensitization, and then we have to figure out what's causing that to start with. Additional Kegel exercises. You can do this while walking. So while you're walking, intermittently tighten the pelvic floor. That's the one that patients typically have some trouble with, just because that's doing 2 things, like chewing bubble gum and walking at the same time. This is doing Kegels and walking. It can get a little difficult and they get a little confused sometimes. During urination, once a day, interrupt the urine stream completely by tightening the pelvic floor. So starting your urine stream and then stop it entirely. And then hold for about 10 seconds and then start your urine stream again. And then after urination, you should try to tighten your pelvic floor muscles strongly to further purge and empty out the final amounts of urine, right? Where we're voiding the urine out of the bladder, which is voiding, which you'll hear frequently. Voiding is also emptying out the back side. So here are just some electronic stimulation devices and biofeedback devices, right? There's all kinds of things you can use with this that measure the actual impulse. There are pads. Obviously, there are some stims that go inside. Same thing for men. These are vaginal dilators. Obviously, sometimes you can have patients where maybe they're going to have a child and they're just not, their opening is not patent enough for it. They can use these. It can also be used as weights to hold in while you're doing Kegel exercises. These are vaginal weights, which also go along with it. So there are various devices out there that can help patients with the overall pelvic health, right? So there's a lot out there that helps them with it. The main thing you need to understand is there's a lot of cases of this problem occurring. I mean, it's not something that's minor. It's very common in women that are athletes, especially gymnasts and people that are already hyper flexible. We don't think of it a lot because it's not reported, but it is a major problem with those people. In men, it's less likely to be reported because men are typically more embarrassed about talking about these things, especially older men, the greatest generations after that, because they're so told that that's not something you should talk about. You shouldn't talk about urinary health with your doctor. When in reality, it's huge that they do, because they can end up with some major bladder infections because of not talking about urinary health. They'd rather just wear a brief and just move on with life and not realize there are ways they can actually treat these conditions, right? So, what I challenge you to do is, can you do these sets of Kegels, right? Go home, you're home now, but practice these. Try doing them 3 sets, those 3 sets of 15 a day, the 5 minutes total of exercises, and see if you notice a difference in your overall pelvic floor in a week, in a month, right? This is just like that 100 push-up challenge, right? It's all dependent upon how much work you put into it. If you are a bodybuilder, I highly suggest you get into practicing your pelvic floor, because all that weight you're pushing down is really pushing that pelvic floor down to yeah, its end. So when it gets pushed down like that from lifting heavy weights and from doing so much Valsalva, eventually you're setting yourself up potentially for urinary incontinence. And I don't want you guys to think about it. You guys should be not having that now. If you treat it now, you are more likely to recover from it if you have it now. Whereas if you wait and you wait till you're older and you get to, my age or after, at that point, now you run into problems where, there's not much you can do about it. So you need to treat pelvic floor health as soon as you notice you're having a problem, or even prevent it by doing Kegels so that you already have a strong pelvic floor and you don't have to worry about it. If there are any questions on this lecture, please shoot me a message. Thanks for listening, and have a good day.